So as mentioned in my intro, I am a pharmacist by training, but I'll be talking today about the diabetes prevention program. And the reason for that is because I've led the implementation and development efforts for our diabetes prevention program at SinfoníaRx, but more globally, diabetes is a huge issue. And so we want to make sure that everybody who has prediabetes or is at risk for diabetes has access to the diabetes prevention program. All right, so our learning objectives for today, we're going to talk about the overview of the diabetes prevention program and the curriculum with that program. And as well, we're going to talk about the diabetes prevention recognition program and the process for that. And then Dr. Layal will take over with the specific implementation within our program, the challenges, some tools for you to use and tips and tricks so that you can have successful implementation of a diabetes prevention program. So starting off with the National Diabetes Prevention Program, we know that diabetes is a huge public health challenge. Over 34 million Americans have diabetes. And more astoundingly, 88 million Americans have prediabetes. So to my point earlier, there's this huge need for prediabetes with that 88 million American figure. And so we want to make sure that prevention efforts are available to those who need it. We know that 1 in 3 Americans have prediabetes. So this is usually where I say, look to your left and look to your right to see which one of you has prediabetes. In the current setting, you're probably not in the room with other people attending this webinar. We do know too that people who have prediabetes, most of them don't know it. So 8 in 10 don't know that they have prediabetes. And then lastly, we know that without intervention, those with prediabetes are very likely to go on to develop diabetes, and in pretty short time period, that 5 years. The cost of diabetes is pretty astounding within our healthcare system. So you can see there the cost to employers and insurers is in the billions, and that's every year. We know that the cost of treating a patient with diabetes is about 2.3 times higher than those without diabetes, and that equates to about almost $17,000 per year for people who have diabetes. And so we know that it's less expensive to prevent diabetes than to treat diabetes. In addition, because diabetes is associated with complications that can occur by preventing diabetes, we also reduce the costs associated with caring for those consequences of the disease. In 2010, the Congress authorized the National Diabetes Prevention Program, and this was in response to overwhelming data that the Diabetes Prevention Program reduced the risk of developing diabetes. It says on here by more than half, but it was really 58% reduction in development of diabetes. And so Congress said, let's make sure we're bringing together all the stakeholders. So that includes community organizations, people who may pay for the program, like private insurers and employers, healthcare organizations like those of you that are on the webinar today, as well as faith-based organizations. And then at the government level, that includes bringing together government stakeholders like the state departments of health or local health departments and other government entities. When people talk about the diabetes prevention program, really most of the time they're talking about the lifestyle change program, which is the program that is delivered to the participants. So the key components of the lifestyle change program are a trained lifestyle coach, which we're going to talk about what the requirements of that coach are. A CDC approved curriculum. Again, we'll give the examples of what the approved curricula that can be used are. And then finally, group support. So we know for diabetes prevention and lots of conditions across the healthcare spectrum that having group support is very powerful in helping people to move forward with conditions, and particularly in conditions where we're looking for behavioral change. So having people who are going through the same thing, are on the same journey for health, are there to support and sometimes commiserate and help to overcome the challenges that can occur along the way is very powerful. So that's a really important component of the lifestyle change program. I mentioned earlier that the diabetes prevention program has shown some significant outcomes. So 58% reduction in the development of diabetes. For people that are over the age of 60, that's even higher. So it's about 71% reduction in development of diabetes in those older adults. But the thing I wanted to point out on this slide is that those results persist. So even after 10 years, people who participated in the National Diabetes Prevention Program were 1/3 less likely to develop diabetes. And those that did develop diabetes had a delay of about 4 years. So it took 4 years longer for them to develop diabetes. So very, very powerful outcomes. And you see those outcomes persist with over time. So I'm going to transition to the Diabetes Prevention Recognition Program. So this is essentially the accreditation program for diabetes prevention programs, and it's put out by the CDC. The guiding document for the Diabetes Prevention and Recognition Program are these standards released by the CDC. You can see they came out in 2018. And then up in the right-hand corner, you can see that they're set to expire this coming year. So we're expecting a new set of standards to be coming out soon. The standards cover these broad areas. So the staffing of a program, the training that's required, participant eligibility, the safety of participants and their data privacy, the location of the program, how the program is delivered, the curriculum that's used, and then the requirements for recognition. We're going to cover all of these in a little bit more detail, with the exception of the safety of participants and data privacy and location. So those are fairly straightforward. And so we're going to cover the others in a little bit more detail. So for staffing and training, the very first thing a program will do when considering a diabetes prevention program is a capacity assessment. So that's part of the Diabetes Prevention and Recognition Program resources. The capacity assessment tells a program how many staff they should expect to need, or how many participants they can expect to be able to handle based on the staffing that they have. The staff roles and responsibilities are also defined. So there are 3 basic roles within the standards. The first is the program coordinator. So that's sort of self-explanatory. This person oversees the program. They oversee the coaches. They make sure the coaches are supported in what they're doing. They identify if there are any issues with implementation and help to resolve those. The lifestyle coach is the person who actually delivers the program to participants. So they interact directly with the participants. And then the data preparer is the person who collects the data and submits it for the data prevention and diabetes prevention and recognition program requirements. So there are specific data elements that are required, which we'll talk about a little bit later. Excuse me. In a small program, all 3 of these roles may be filled by the same person, where in larger programs, you may have individuals in each of these roles. I wanted to go back to the lifestyle coaching for a moment. So as I mentioned on one of the previous slides, there are specific training requirements for the coaches. So the coaches have to go through a CDC approved curriculum. On the right here, I've listed the current CDC approved sites for coach training. So the coaches go through a training that includes both an overview of the required CDC curriculum for the program, but they also gain skills such as group facilitation and motivational interviewing as part of that process as well. The Diabetes Prevention and Recognition Program outlines participant eligibility. So in order for participants to be eligible for the program, they have to have prediabetes or be at risk for diabetes, plus they have to be overweight or obese. So let's dig into those a little bit more. In order to have a diagnosis of prediabetes, that's those labs that are the first 3 bullets there. So they have to have a fasting glucose of 100 to 125, a postprandial glucose of 140 to 199, or an A1C of 5.7 to 6.4%. In addition, participants can be eligible if they're at risk for diabetes. So that could be a history of gestational diabetes or diabetes while pregnant, or that could be a positive screening on the CDC's Take the Test, which I've included the link there. So this is a 7-question questionnaire that goes through different risk factors. People who score 5 points or higher on this risk test are considered at high risk of developing diabetes. In order to qualify based on overweight or obese, that means that people have to have a body mass index of 25 or above, or for Asian Americans, that's 23 or above. So if they meet one of the criteria from column 1, one of the criteria from column 2, then they're eligible for diabetes prevention with the exclusions listed there at the bottom. So people have to be adults, they cannot currently be pregnant, and they cannot have an existing diagnosis of either type 1 or type 2 diabetes. The diabetes prevention program can be delivered via one of 4 ways. So in-person programs, online programs, distance learning programs, or a combination of any of those 3. So I just wanted to point out the online program and distance learning, just the difference between those. So the online programs, participants access digital content, usually web-based, in order to participate in the program, versus a distance program that includes a telehealth component with the coach. I mentioned that a CDC approved curriculum is required for the diabetes prevention program. So on the right here, there's the 2012 National DPP Curriculum and then the PreventT2 Curriculum. Those are really the main curricular options for the program. But there are alternate curricula that can be approved by the CDC. So I've listed a few of them that are currently approved. So adaptations for Chinese, Vietnamese, and Spanish speakers, as well as the Native Lifestyle Balance Program for Native American populations. If your program has specific language or cultural needs, you can apply for an alternate curriculum to be approved by the CDC. Within any of the curriculum, on the left-hand side of this slide, you see the layout of the program. So the first 6 months are what's considered the core sessions. And so the core phase of the program is a weekly session for a minimum of 16 sessions. In the second half, we move to core maintenance. And so in the core maintenance phase, those sessions move to monthly at a minimum. Digging in deeper into different phases. So in the core curriculum, and so remember that's the first 6 months, this really covers the skill acquisition and those really fundamental skills for participants to be able to set and achieve goals. So if you look over to the right, we have the 2012 National DPP Curriculum and the PreventT2 Curriculum that are listed out there for the first 6 months. You can see over on the right-hand side, over under the PreventT2 curriculum, the track your activity, track your food, eat well, get more active. So those are really fundamental, teaching participants how to look at labels, how to be active, and then how to track those things in order to be successful with their goals. The goals during this phase are to reach 5 to 7% of weight loss and to get at least 150 minutes of physical activity each week. For the core maintenance phase, this phase really focuses more on the challenges that can occur with weight loss and activity and maintaining that, and then the overcoming the challenges that can occur. So again, if you look over to the right, under the PreventT2 curriculum, there are some things under there about staying active when away from home, eating well when away from home, getting back on track when weight loss or activity gets off track. So again, really focusing in on making sure that we can maintain those behavioral changes long term. The goals during this phase are to reach or maintain that 5 to 7%. So for those who have not reached the 5 to 7% weight loss, they can continue working on that. For those that have, they can maintain. In addition, people who want to or need to lose more than 5 to 7% of their body weight, they can work on additional goals, trying to lose more, and then maintaining that 150 minutes of physical activity each week. There are 3 different recognition statuses under the Diabetes Prevention and Recognition Program. The first is pending recognition. And so this is the status that programs are in once they've met the initial requirements for application. I've linked in the application there for you as well. During this phase, programs have to submit data every 6 months, and they can't be in this phase for more than 36 months. The next phase is preliminary recognition. So once programs have 5 eligible participants that meet certain data requirements, they move into preliminary recognition. The requirements for those at least 5 eligible participants are that they have to have attended at least 3 sessions in the first 6 months. They have to have been in the program for at least 9 months. So at least 9 months of the program has to have elapsed. And then they have to have 60% attendance in the core phase as well as the core maintenance phase. So for the core phase in that first 6 months, they have to have 60% attendance in at least 9 sessions. And for the maintenance phase, it's 60% in at least 3 sessions in that second 6 months. The last recognition status is full recognition. So programs that are in full recognition have data for at least 12 months and at least 1 cohort. They have to meet the same requirements as for preliminary recognition with those 5 eligible participants, but in addition, they have to meet additional requirements for weight documentation. So they have to have documented weight for 80% of the sessions. They have to have had documented physical activity for 60% of the sessions, and then an average of 5% weight loss across all of the eligible participants that they're reporting on for that period. The last item under full recognition is that 35% of the participants have to have been eligible for the program based on laboratory tests or gestational diabetes history. So remember the laboratory tests are fasting blood glucose, postprandial blood glucose, or hemoglobin A1C. I wanted to just touch on Medicare. So the Diabetes Prevention and Recognition Program are the CDC requirements, but Medicare, in order for Medicare billing, they're a little bit more stringent requirements. So Medicare requires that programs either be in preliminary or full recognition. status. The program delivery has to be in person. Right now, because we're under a COVID exception, programs can deliver their programs via the other modalities, but ordinarily Medicare requires that to be in person. Additionally, participant eligibility is slightly different. Medicare requires that all participants are qualified based on those lab values, so fasting blood glucose, the postprandial, or a hemoglobin A1C. And then the fasting glucose range is slightly more stringent. So for normal participation, it's 100 to 125. For Medicare patients, the fasting glucose range is 110 to 125. So at this point, I'm going to turn this over to Dr. Sandra Leal, who will continue on with the presentation.
Thank you, Dr. Scovis. That was an incredible presentation, a lot of information. Hopefully we are really exciting you with this new program, with the diabetes prevention program, and trying to really speak about how we're trying to partner with NCFH and with different programs to try to make sure that this program is available across the country. So one of the things that we really wanted to do is make sure people had access to this, especially if they experience barriers such as language or things like social determinants of health, transportation, childcare issues, things like that. So that was how we really thought about creating a program to do that. As was mentioned earlier by Sylvia, I'm a certified diabetes educator, also a pharmacist by training, and my career really started at federally qualified health centers. I worked at El Rio Health Center for 14 years in Tucson, Arizona, and I actually started a diabetes self-management training program that was accredited by both the American Diabetes Association and the American Association of Diabetes Educators. And one thing that I saw was that we just had a lot of people experiencing diabetes. And so a focus that we wanted to do is focus on prevention, because we see that, there's a lot of people that need diabetes treatment, but then we're seeing a huge line of people, 1 in 3 now, that are at risk for diabetes. And I feel it's compounded now more with this year, especially, where people have been challenged with being able to do the usual activities. There's so many limitations that are happening right now. So it is an opportune time to be able to intervene in this way. We didn't design this program with COVID in mind to be able to be accessed through telehealth, but what happened is that because of the situation, this program became even more important to create opportunities for people to be able to reach this program in a way that they could access it through either telehealth or a hybrid model, or some sort of paired opportunity to provide that reach. So what I wanted to do is describe that a little bit in the next slides, and some of the experiences that we've had. So a little bit about Sinfonia Rx. The organization that Nikki and I work with started at a college of pharmacy, at the University of Arizona College of Pharmacy. And what we were trying to do there is work with patients who experienced chronic conditions. So our company started off as a medication therapy management company. And then over the years, we've grown and we were acquired and joined a company by the name of Tabula Rasa Healthcare. And so the group within our organization is really led by pharmacists and a lot of IT. We use a lot of technology in the work that we do, and we focus on optimizing medication therapy for people that are experiencing barriers to care, that have numerous medications. So it made a lot of sense when we saw this program with DPP to try to address that, because we see a lot of people, especially those that are Medicare age, that end up with a lot of medications. People with diabetes tend to take anywhere from 10 to 12 or more medications, and then have chronic comorbid conditions. And so this program made a lot of sense. How do we delay or prevent people from doing that? So our programs have grown to over 1,500 members across the United States. We partner with colleges of pharmacies and groups like National Center for Farmworker Health, because we want to make sure that we are allowing for people to be able to have a relationship with their providers and have a pharmacist be part of the solution, so people have better outcomes. So right now, we currently have 7 clinical call centers, and 4 of them are academically affiliated. One of them is at the University of Austin in Texas, another one at the Ohio State University, Drake University, and then we started our program at the University of Arizona. So we still partner with the University of Arizona. We'll go to the next slide, please. One of the things that we've been able to do is partner to develop this program with the Centers for Disease Control and with an American Pharmacists Association Foundation. So we ended up working on designing this program through the 1705 grant to try to scale diabetes prevention in underserved areas. And that was the intention of the program, how to be able to reach people who are challenged because they're either in a rural setting or they're medically underserved or in underserved communities that might not have access to programs like this. So this opportunity was a 5-year initiative, and they were trying to enroll over 7,500 patients. And we were one of 10 different CDC cooperative agreements to receive this funding. So we were really excited to figure out how to take a model that we were using for medication therapy management and then apply that to diabetes prevention program to be able to reach numerous people, regardless of their geography and then regardless of their language, because we wanted to be able to help support them in that way. Next slide, please. So one of the things that we did is we took that model of medication therapy management and we leverage the same resources that we had, but then applied this DPP program to that. So we have certified pharmacy technicians that we trained as lifestyle coaches. Because we know that pharmacies are located in communities where people go, we also wanted to partner with community pharmacies to be able to be an access point for patients that go pick up their medications and use that pharmacist as an accessible provider to them that then was coupled with some of the work that we do with a telehealth model here. So we train over 90 trained lifestyle coaches. We have them trained in English and Spanish, and actually through our services, we have about approximately 30 different languages that we support for our medication therapy management program. So our goal is to make sure that when we are doing outreach for people, that we're able to support them in their language of preference. And this really optimized the way that we developed the program. If you've worked either in a diabetes health management training program, or if you've actually worked with a DPP program, it can take a lot of resources to get a program accredited, to get the staffing for it, the space, even a room to hold the classes. What we tried to do is really create internal efficiencies with the experience that we had with medication therapy management and apply that to the DPP model to make it scalable, affordable, and then to be able to partner with groups that might not be able to stand up a program on their own, but assist them in doing that or be able to help support them in doing that more effectively and more efficiently and more sustainably, because we want to make sure people do have these resources available to them regardless of barriers or challenges that they might experience. So we did this training and we combined a lot of training programs, numerous hours to get our staff ready to go for this program. I mean, we continue to evolve because this is really one of the first programs that's being offered in this hybrid model with all the options that we spoke about. So it is something that we're also learning about and evolving. And then from what we learn, we apply it to get better every single time and with every single patient that we work with. Next slide, please. So the areas we really focus on are screening, testing, and referral. And we've looked at a numerous number of different partners to be able to do this to prevent type 2 diabetes. We're not just working with one group, but what we try to do is really work on designing programs that have a lot of different outreaches and different partners, because it really takes a great effort by our community to be able to do this. And when we're talking about the scale of 1 in 3 people that experience pre-diabetes, we want to make sure we're targeting different relationships and different partners to be more effective. So when we look at different partners, we're partnering with health plans that are already working with patients. They might have been working with us on medication therapy management, but then we also use this as an opportunity to see if this diabetes prevention program is something that they want to complement or add to a program that they're already doing to reach a certain outcome. We work with employer groups. A lot of employer groups are taking on more responsibility for the cost of their patients or their employees. So what we try to do is work with them to see if we can offer wellness programs or things that would benefit the employee having better success and overall decrease the cost of care for these individuals. Because we're pharmacists, we also work with colleges of pharmacies. If we have an opportunity to do that, a lot of times the students are very eager to be out there and doing health fairs or screenings. And these colleges also bring us other relationships, like relationships with colleges of public health, colleges of nursing. So a lot of these groups that are out there already doing this work can now have a referral source where they can send a person who might experience prediabetes and not yet be connected to care, so we can work with them to make sure they have access to care, they're going to a provider, and making sure that they have that reach that they need. Other groups that we've partnered with here include community pharmacies. I mentioned that earlier. If there's a pharmacy in the community that they can tap into and be a local source of support, we want to partner with those communities and be able to do that outreach for them. Other non-for-profit groups that we partnered with include the Ventanillas de Salud program with a Mexican consulate, and that's been a wonderful partner here in Tucson, Arizona, where I'm currently located. We've partnered with a Ventanilla to be able to be a resource to them if they have people walking in having questions about pre-diabetes or diabetes, so that they also have an ability to connect someone to a class or to services that might otherwise not be available. So these are just some of the ideas that we've been able to leverage to be able to do these screening, testing, and referral opportunities. Next slide, please. As Nikki mentioned, we do have a combined delivery. One of the things that we wanted to do is really create the content so it was available on demand. As Nikki was describing the curriculum, you saw that there were numerous classes that a person has to participate. And historically, the classes have to be face to face. But with what we've done is we've actually created the content to be on-demand digital. And the way we thought about this is that people really sometimes have challenges. They maybe cannot go to a class, for 6 months in a row, once a week, or they might have challenges with being able to attend all of them. Maybe they can attend a portion of them. So what we ended up doing is creating the content on demand in English and Spanish, so a person can access it at any time that's convenient for them. These classes are pre-recorded in English and in Spanish, and so a person can watch them on a tablet, on a computer, or if they don't have the ability to do that, they are also pre-recorded so a person can call in and listen to the information telephonically. So you don't even need data. You could just use the voice option to hear the classes. And we were very intentional of trying to keep them to a minimum amount of content. So it wasn't like a 40-minute class, but maybe like 15 minutes, 10 minutes. So the content is very specific and then coupled with the coach that then checks in with the individual and reinforces the information or answers questions for the individual and makes sure that the person is active and really maintaining the lifestyle goals, the weight loss goals for them. So that was the thought of how we developed this program, to be very intentional to meet the needs no matter where the person was at. So that telehealth component is very key for us. And then a participant portal where they could be checking in and looking at information, documenting some of their successes. So these combination delivery models are really to create flexibility for individuals, to make it as easy as possible for them to be able to do this without the barriers that are otherwise existing in the system out there. Slide, please. So these are some of the tips for success that we've identified that we wanted to share with you. The hurdles when we look at some of this is there's hurdles that are out there for public awareness. As Nikki mentioned, a lot of people don't even realize they have prediabetes. So just even the knowledge of whether or not somebody has prediabetes is very critical. Screening, testing, and referral is the next step. Once you help somebody be aware, how do you get them to actually do that next step? And then the enrollment and retention, other critical items. So I'll go through these individually. Next slide. So some of the public awareness strategies that we've been using is really trying to focus and partner with the CDC, the American Pharmacists Foundation, and anybody else who's doing some of these prediabetes to do some public awareness campaigns and get the word out. And so this is part of our opportunity with National Center for Farmworker Health, is to make sure that people realize that this is a significant problem and that we want to partner with you and the populations that you serve to be able to screen people, and so that they know what resources are available. We use a lot of social media to be able to do this. There's been a lot of content that has been put out by NCFH and then by our group also, to engage people where they're at and where they're going to receive information. We definitely encourage participation at every single visit. Anything that we can do to screen people. Sometimes it's as easy as taking a questionnaire. You don't even have to have a lab to be able to do this, but to get people engaged to realize what they can do. Some of the tools and resources are available are incredible. The CDC has done a really great job of funding some very great content out there, and they've been very thoughtful about selecting vehicles where people go to. So, as an example, some of their public awareness videos are out in Telemundo. They've engaged people and celebrities that people would be familiar with. They've also created infographics to make that content very appeasing to patients and to see that the information can be something that they can quickly access. This is really very key. And there's even a marketing toolkit that you can use within your institution to be able to share information, things like flyers, things like videos, things that you can share to really help you create that awareness within your organization and for the people that you serve. Next slide, please. Some of the screening, testing, and referrals are some of the most critical outreach points to be able to actually engage patients. Some of the strategies for success is really holding screening events. And that's been probably one of the more significant challenges right now during COVID. It's that people haven't been out to the local, health fairs as usual, or having screening days or health fairs like historical. So that's been a little bit of a challenge, but I think as things are opening up again, and as we're starting to see a lot of people that deferred care, it's creating a new opportunity to screen people and ask them about their lifestyle. Have they been active? Do they have risk, to get them into this program? So those are really critical for us. Some of the most effective way to do that is through mobile health units, some screening tools that are out there, but then also providing opportunities to educate the team and make sure that if they're seeing a person, if they have a touch point with an individual, that they recommend that screening so that they can actually get evaluated and then join a program such as this. Some of the other things and tools that are very effective are making sure that there are standing orders for screening patients, and then also having integration within the electronic health record. So if you're seeing somebody who might be high risk, that again, this is an opportunity for screening to make sure that if they qualify for the program, then they're able to participate. So some of the tools available, again, I refer to the CDC because they have some incredible tools that they've really looked at and designed, some experiences from others that are really helpful, referral strategies. So these links are available and we'll be able to share this information with you. Some of the pitfalls of this are, program availability. And this is probably one of the areas because this program, DPP, is fairly new as it relates to the CDC and approving it. There are not a lot of accredited programs across the country yet. So you might be screening a person, but there might not be a program available locally, or there might not be a program available in the language of choice for the patient. So for example, there might be an English program, but there might not be Spanish classes for a Spanish speaking population. And so this is one of the things that we were trying to overcome with the program that we developed is no matter if there's a local program or not, we could leverage this program to be able to reach people. Or if there is a local program and the person can only participate a portion of the time, we could create maybe a dual program, a hybrid program where the person goes into a few classes and then potentially finishes or does in between classes with a telehealth component of it. So that's to try to provide continuity for the person and make sure that they are able to complete the entire curriculum. Next slide, please. Now, patient engagement and retention is the next big hurdle. So once you've identified a person and once you've referred and screened them, it's really important to make sure that the person actually engages. And this can be challenging because there are a lot of classes. So you want to make sure that the person tries to complete as many classes as possible, ideally all of them. If we see that people complete the classes, you can see up to a 58% reduction in development of type 2 diabetes, or you can delay the diagnosis of diabetes, and all of those are good outcomes. But sometimes it is overwhelming. People have competing priorities, and so it can be difficult to engage people and to retain them for the full curriculum. But there are some things that you really want to do. Definitely create a personal connection, provide the services in the language, as we mentioned earlier, create excitement around the program. If you find somebody who's at risk and they can partner up with a family member who's also at risk or a neighbor, and you have two people participating, that might motivate them both to come as opposed to one person who's doing this by themselves. Other programs that we're considering are incentive programs to really engage people, things like potentially coupons or some sort of activity, maybe a discount for a health club, things like that that would activate the person and make sure that they continue to maintain that activity within the program. And then, as we mentioned earlier, the opportunity to leverage technology to be able to make it as easy as possible for people to participate. Those are strategies that really have helped us to be more successful or can create more success for your program moving forward. Some of the tools and resources, again, that were provided by some of the partners here, incentive programs or studies to show that incentives work. So we listed some of these here. NACDD, they also have some spotlights on what to do for certain sessions. And then the retention tools that CDC has put together are really personal success tools that you can use to implement within your program if you're seeing that some people are falling off. But some of the things that we know are not good, that are pitfalls, are transportation issues, childcare, language issues. And those are the things, again, that we try to overcome with programs like these, to partner with what you have or to create opportunities for people to not experience these barriers and to have more success. So as I mentioned earlier, these are all things that we're learning. We're learning collectively with you, and we're trying to partner with groups to be able to make sure that we have these available programs to have the most success available and possible, and to be supportive to the people out there. So with that, we'll go to the next slide. We just wanted to make sure we had enough time for questions, and thank you so much for your participation. I put my email here and Nikki's email here. If you have any questions about any of the content, please feel free to reach out to us. Thank you so much and stay healthy.